go. My name is Kara Hatcher. I am the U.S. Director of Commercial Initiatives and thrilled to host our second Fellows in Early Career Implanter webinar tonight. We have a robust faculty panel excited to share and provide you with knowledge to empower you as you treat patients in your community suffering with mitral regurgitation. Abbott is committed to our partnership with you through MitraClip Technologies, and tonight is an example of just that. I'll read through our disclaimers. We are so thrilled to have Dr. Nadira Hamid, who recently joined the Minneapolis Heart Institute and the Cardiovascular Imaging Research Center at MHIF. She's a non-invasive, board-certified cardiologist who specializes in echocardiography and interventional echocardiography. She is a board-certified in both echocardiography and echo-computed tomography. Dr. Ryan Kaple is director of the Structural and Congenital Heart Program at Hackensack University Medical Center in Hackensack, New Jersey. Dr. Kaple is an internationally recognized expert in minimally invasive mitral and tricuspid valve therapies. And with that, I'd like to hand this program over to Dr. Nadira Hamid.
First and foremost, thank you so much to Abbott, Kara, Alicia, and the entire team for putting this amazing program together. And I'm truly honored and privileged to be part of this. And together with my colleague, Dr. Ryan Kaple, we are both excited to be sharing what we have with regards to MitraClip and mitral regurgitation. And so I've been given the task as an interventional echocardiographer and to talk about TE imaging in the MitraClip, the basics, and really optimizing the views. These are my disclosures. And as we start off with mitral regurgitation, there's so much in the literature. We have come a very long way, but really, to our surprise, it still remains undertreated. Numerous studies like this one by the Mayo Group, you can see that, these patients do have excess mortality in every single subset. Only 1 in 7 had surgery, and these patients do have recurrent heart failure hospitalization in at least 2/3. And so we see a lot of these patients, and really, how do we treat them or investigate them to see whether they're suitable for any form of transcatheter mitral therapy. And that's reason because, these patients are high-risk individuals, and going for open heart surgery may deem them high risk. And so what are the options? So you heard a lot in the literature, in numerous conferences or webinars with regards to repair and replacement. And repair with the transcatheter, the TEER device, is really widely available. It's transfemoral access. You have a short, long length of stay. It's not a prosthesis. Don't really need anticoagulation unless the patient is atrial fibrillation. It's really life-saving and the improvement in the quality of life, and including heart failure and hospitalization and mortality, which we've seen in the literature. And of course, replacement is exciting therapy. We heard a lot. There's several devices, transcatheter mitral valve replacement, all in clinical trials, but certainly it has its advantages for some patients. And of course, there's no residual mitral regurgitation. And so the clinical decision for TEER, you might have heard the red, green, or the yellow zone, but really from this paper in 2020, you can see in terms of optimizing the therapy and the imaging. So from beginners to intermediate to expert, you can see a whole variety of spectrum of mitral valve disease, from an ideal case to a more complex case to really advanced complex case, which both me and Ryan will be sharing with you a couple of flavor of these cases in the next 1 hour. And so MitraClip, comes in 4 sizes. We have the G4, NT, NTW, XT, and the XTW, and you can see the rationale of the different sizes. In terms of the width, 50% wider in the grasping area for the NTW and the XTW, and the length of the grasp as well, in terms 9 and 12 millimeters for the NT and the XTW. And so really the anatomy of the, in the imaging is so important in some of this decision making, which we can discuss with my colleague Brian as we go through the cases. But really, I would love to talk about, TEER as a restoration coaptation. You can we should be appreciating the mitral valve anatomy. So you can see the natural leaflets of the mitral valve. And, in some cases where you have different asymmetry in the height that leads to the mitral regurgitation, or in functional mitral regurgitation where you have short coaptation and leading to central mitral regurgitation. But all in all, the main purpose of TEER therapy is really to establish and restore coaptation, as you can see, so that to reduce the residual mitral regurgitation. And ultimately, this is not an Alfieri stitch. And so restoring the coaptation is so key. And we have great examples in the next 1 hour to show you this restoration of coaptation reserve in terms of the grasping segment, how many leaflet grafts in terms of the length of the leaflet, at least more than 5 millimeters. And imaging is so key intraprocedurally to ensure adequate leaflet grafts to avoid the single leaflet detachment. And so there are in the literature with regards to coaptation reserve. And this is really important because you get a really optimal MR reduction. And so what is coaptation reserve? You've seen it in papers, but here's a diagram. You can see the leaflets and the coaptation reserve at the tip of the leaflets and the height of it. And so the more you restore that coaptation reserve, you get an adequate MR reduction in these patients. And so you can see the image on the right-hand side, the clip having a natural symmetry, restoring that coaptation reserve of the natural state of the mitral valve to reduce that MR with the TEER therapy. So determining it, as you can see on the left-hand side, an optimal MR reduction in coaptation reserve with a MitraClip. And on the right-hand side is something that is acceptable, and that's because in atrial functional MR, there are some cases where it's too feathered, and so the coaptation reserve might not be optimal, but still acceptable in terms of MR reduction. And in this paper by my colleagues in MHI, it's really we showed in our cohort of patients in terms of this coaptation reserve and the cutoff of 3 millimeters have shown in terms of not only MR reduction, we also showed in outcomes in terms that these patients had greater long-term survival because you have a better MR reduction with the TEER therapy. And so our aim is really to restore that coaptation reserve. And so in terms of anatomical considerations for the MitraClip, you want to look at the leaflet length, you want to look at the length of the jet, you want to look at the valve area in terms to determine the different types of clips for the decision making. And so back to TEE imaging, that's where I come in for these cases, and even preprocerial imaging, I think is so key to determine whether the patient is suitable for TEER imaging. And is there anything else, Ryan, that you would like to talk before I go into the imaging, as I just highlighted a brief introduction to the TEER therapy?
No, that was great, Nadira. I think that the pre-imaging is where all the planning happens, of course. And so I think, a lot of us think through these cases in real time, and you're sort of rebuilding that coaptation line and that coaptation zone and the restoration of coaptation in your head. And so I'm always, we're looking at the tenting and, how much leaflet override there is and how much free leaflet there is. Because when you have a lot of tethering, some of the cords kind of disrupt the continuity of the leaflet and will impact how it may react to the leaflet. So I think we have some really good examples coming up of that. And so, but really that stoplight system, the kind of green, yellow, and red, it's a great way to put these cases into boxes because they're so complex. So I think for our fellows who are really starting their practice soon or in the early years as being an attending, I think that's a really great place to always go back to.
Correct. And with imaging, and that's what we look out for. And we, communicate with you, Ryan, right? Interventionists, to see these are the challenges, potential challenges that we have to think about. And so, it is a great start. Our American Society of Echo, actually this weekend, we have our annual conference, and they have been an advocate for interventional echo. So all these key opinion leaders on this, paper that's just came out, I believe in last 1-2 years, talking about the standard structural imaging for the various cases for aortic, mitral, and including tricuspid. So it's here for the mitral, we deem it as planar, volumetric, and functional. But if you take it down, it's similar to 2D, 3D, and quantitative assessment of the mitral regurgitation. And so, you go from 0 degrees, and one of the key views, I'm sure, Ryan, you agree, is the commissural views. And and this is an example of a case that I did. So you can see the commissural view and how we determine if it's a commissural view. When you do a biplane imaging, you can look at the orthogonal view that you see a long axis view equivalent. And you can see on the left-hand side, my commissural view is not exactly 60, but in between 60 to 80. So you have to adjust your degrees as you go forward and determine what is the true commissural view. Because patients lying on the side doing pre-screening or on the table, right, Ryan, it varies accordingly. And depending on anatomy of the heart, being a horizontal heart, depending on their spine as well. And so commissural views with biplane imaging, I think is so key. You can see on the right-hand side, the long axis view. You appreciate the leaflets, the Barlow's leaflets, the myxomatous leaflets, and you can also see the mitral annular calcification in the and maybe a little bit of mitral annular disjunction as well. So certainly you can see color and no color as well, the color Doppler, a lot of the Pisa jet originating laterally to your A1P2. And also then moving along to your mid, as you move, the biplane imaging to the mid, and I take color and no color, in the same spot, showing to Ryan as well, hey, this is where a lot of the jet still is. So you have a lot of the jet laterally and also in the mid A2P2. And then you sweep again to the medial side, not only looking at where the jet is. I think, Ryan, it really is like the other key point that you'll be looking out for is the length of the posterior leaflet, right, Ryan? And seeing the length of the grafts. And if the length of the leaflet is adequate for an NTW or an XTW, those are the key consideration points that you want to think in your decision making for in terms of the selection of clips for these kind of cases.
It's a great point, Nadira, in terms of the leaflet length pre-imaging, because I always go back to the pre-leaflet length to get a sense of how much leaflet you actually grasped. I mean, you have a certain goal depending on the clip, whether it's 6 or 9 millimeters, but the only way to know that is to have a nice view throughout the almost sweeping through the from the commissure to commissure. So wherever the clip ends up, you have a pre-image view to kind of get that pre and post leaflet length.
That's right. And I would advocate, take your time. If it's pre-screening or even on the table, don't rush, take your time with adequate sedation, calm the patient down. I know it's in a moderate sedation can be quite challenging, depending on the blood pressure, but take your time to get the views because these are key views in terms of the decision making. And so moving from the commissural view, then obviously as you move forward from 75 to 90, and then of course the long axis view. So this is the view, you see the length of the posterior leaflet, where the jet is, and certainly in terms of the grasping view, I think we use a lot of this long axis view to determine the length of the leaflet into the clip, which you'll see in a couple of cases that we will be showing in the next couple of minutes. And then moving along, not forgetting 3D. I think this is so important. It has really revolutionized how we look at the mitral valve and the other valves as well, mitral and tricuspid. And so, we look at multiple views you can see in the atrium. And what I also do is you flip it on the other side to really look at from the ventricular surface. And you have another feature on the console of the machine, a dual layout. So you just click on it and you can have two views at the same time, atrial and ventricular. And one of the key points, things I do, Ryan, is that looking at the ventricular, you can see a little indentation. You can see right next to the A2P2 on the medial side, like a little fold, and you can also determine if the patient has a cleft as well, a deeper fold all the way to the annulus. I think this is so key. So to really understand the anatomy of the mitral valve and understand the etiology of where the mitral regurgitation jet, because in terms of, planning during the MitraClip process. So I love this view, atrial and ventricular, to have a real understanding of the mitral valve. And this is a case I actually just did last week. And you can see this patient with really on the left-hand side, a lot of mitral annular calcification on the anterior and posterior annulus. And I flip it on the other side as well, the ventricular surface. You can see the opening, certainly just visually is severe mitral stenosis. Absolutely not an indication for TEER, but, just want to highlight, this dual layout and the severe MAC and planimeter of the mitral valve certainly fits with severe mitral stenosis. And besides those imaging, 2D and 3D, what do I provide to Ryan is really that quantitative assessment of severe MR, which I'll show you in a second. Besides 2D, PISA, which, all of you know, we do a lot of 3D vena contractor area. Mean gradient, I think is so key. We do a next step, not only mean gradient, mitral valve area using 3D, and then looking at other qualitative parameters, pulmonary vein reversal, in determining is it 2 out of 4, 1 out of 4, and where's the reversal depending on the jet. Not forgetting to outrule thrombus as well in the left atrial appendage. And of course, Ryan will check the left atrial pressure pre and post after clip to see the hemodynamic improvement with the TEER therapy, with the reduction of the mitral valve. So here, the 3D vena contractor area, you can see is an acquisition of it in the 6th beat. There may be stitch artifacts, but on the table, you can ask the patient to, the anesthesia to hold the breath. And so while you acquire this, and on the right-hand side, you do a mitral valve area planimeter and using the 3DQ software on the console of the machine. And here it's certainly adequate enough. Anything more than 4 is adequate. And you can see the mitral regurgitant all along the commissures with a large vena contractor area of 1 centimeter square. Certainly beyond severe to me would be torrential. And I think giving Ryan all these parameters, am I correct? So key, especially in your thought process too. And as we discuss these kind of cases in the valve meeting, don't you think these are the key parameters that you would need to make the decision of whether a patient is suitable for TEER therapy?
Absolutely. And you mentioned the piece about the sedation, which can be challenging to get that perfect level. And the thing that all changes with that level of sedation is the blood pressure. We know that can be really challenging. If you don't have as much MR at the time of the TEE, is it because the blood pressure needed to be lower due to sedation? So I really find it helpful when the person doing the imaging on the pre-screening will put the blood pressure on the screen when it's time to do the quantitative assessment, so that when it comes time to make decisions afterwards, you have that at your fingertips. You have the blood pressure, because we know it affects the loading conditions in such a big way.
Oh, that is such an important point. I do that too a lot, put the blood pressure on the screen and then discuss the case. So I know what's the blood pressure. It's easy when a patient is under general anesthesia because you can ask assistance from them to push the blood pressure up. But it's really hard in the outpatient settings under moderate sedation. But certainly great point about the blood pressure for these patients. And then I thought about, adding a little section on transeptal, because, I would say, Ryan, you agree with me that this is for the procedure, this is such an important step that can really make or break the case, I feel. Make it a short case or a long case.
Right. Well said. I don't need to say anything else. That's exactly right. It's still the part of the procedure that I kind of still get a little concerned about, because it's make or break at the beginning of the case. I agree.
Exactly. And I would advocate take your time for this part because, don't rush the transeptal because once you get it, it's just smooth sailing from there, hopefully be all, obviously there's next other steps, but I think this is the really important step too. And I think adding in the transeptal guidance, right? We use the bicable view, the short axis view, and really confirming the height in the 4-chamber view. There are limitations to that, which I'll show you, and what we can overcome as imagers during the procedure. So this is just an illustration from really that paper that really sets, about the transeptal view in the bicable and short axis view and how it looks like it, in really assessing it in that 4-chamber view. But I've been using a lot, Ryan, of 3D MPRs, and I can show you in one of the slides later on why I think it's so important, especially when you can't get a true 4-chamber view. I think it's so, it has really revolutionized how we do transeptal and confirming it. And so I added a few fluoroscopy images like, Ryan here, the wire, into the sheath and the sheath into the SVC. I think during this part, I think it's so important as images, make sure you see it in the bicable view, and determining that as they come down. And Ryan, which view do you think usually you use, right, while crossing? And I think for me, it's so important to communicate with the interventionist during this part because, I think that's when mistakes happen. And I think this is the very important part that, the imager and the interventionist have to communicate during the transeptal part, and which view, in terms that you can see the bicable view on the left-hand side, the short axis view, and the right-hand side is really measuring it, but certainly is, kind of foreshortened. Ryan, what are your thoughts?
Yeah, the bicable view is key. And I think part of the goal of tonight is also to talk about program building and how this kind of relationship between the imager and the implanter can be developed and why it's so important. And the themes that have already come up are taking your time, being patient, and waiting for the right view, the best view, so you can make a good decision. And I think for me on the transeptal, it's the bicable, and then just waiting, cutting an straight axis through a short axis through that bicable view, and just being patient and making sure you see a good tent, making sure it's safe. This is really the time to slow down and make sure that communication is two-way, back and forth, so that everyone feels comfortable. And I always do it triple check before we use the radio frequency to go across the septum, and making sure that everyone in the room, including the clinical representatives, feel comfortable, because this is the time to make sure everyone's on the same page for sure.
Correct. And you will always ask me as well, the imager, in terms of, can you confirm the height again before puncturing? So
yeah,
absolutely.
and if you have to get a different position, definitely do it. If there's any question that it's not where you want it to be, start over, because this is where you really, aside from starting off in a safe way and getting across to the left atrium safely, you do set yourself up for success. And we have some good, I think it's nice to spend some time in terms of where to position the transeptal puncture. We have some good imaging to demonstrate that.
That's right. And so, and really understanding the anatomy, continuing from Ryan, and that's so important. You want to get to the superior fossa for most cases, and that's your bicable view. And then obviously, you from your bicable view, moving to your short axis view, like what Ryan said, confirm that you're away from the aorta, you're safe enough, you're still in the thin part. And, and then the other bit is checking the height of it. Of course, standard is using 4-chamber, but I've been using a lot of 3Ds, and I'll show you in a second. And there are always a lot of cases, right, that you want to gain height. It's like you're at 3.7 or 3, you want to gain a little bit more height. And how do you really do it? And so, you want to move in superior inferiorly on the fossa. It moves the needle anterior posteriorly in relation to the mitral valve. But some of the superior movements, it changes the trajectory. And so you have height loss. But I think the key concept, correct me if I'm right, Ryan, that, your clockwise rotation of the needle moves you away from the mitral valve. So you gain height. And so you can see that you're gaining height, just move clockwise rotation in that. You can see that pink, the yellow, but counterclockwise moves you towards the mitral valve. So you kind of lose height. And so always, double check, triple check, clockwise it. And so this is just an illustration of it. Clocking it, you kind of gain height away from the mitral valve. And once you make small movements, feel free, Ryan. I'm sure you're going to ask me, can you just double check where did we move, right? Is the communication, I think you and I, both of us, the imager and the interventionist. If you make small movements, always check with us imagers, did I move? Where did I move? And if your imager can't find you, give her or him time to locate where you are, because some of the small subtle movements changes the images. Am I right, Ryan?
Absolutely.
You will wait for me, and then I will try and find you, and get the image where you're pointing and check, is it safe? What's the height? And then you do this repeatedly until you're comfortable with the puncture. And so
anytime you manipulate the device, whether it's clock or counter, but also some of the newer devices you're going to have the needle exit your transeptal guide, and that can shift things on the septum depending on how deep the tent is or not. If you don't have a very deep tent, it may slide a little bit. So really, up until the last moment, until you buzz it, you can move. So check and recheck and empower each other to allow the other person to take their time. They're really and that goes for the whole procedure. You're really a team throughout the whole procedure, and giving each other the latitude to be confident about the decision making is key.
Absolutely. And I hear you, Ryan, and I'll wait for you and you. So vice versa, it's a team effort. And so, one thing as well, after you gain height, sometimes this is cautious, you may move actually lateral. So really, you need to as imagers, really determine where is the needle, before he punctured through, because sometimes they go all the way lateral, they might perforate and go outside the heart. And it has happened before. And so take your time, like what Ryan was saying. And so this is just a CT imaging of, if the patient had a CT, you can actually ask your CT imager to do measurements in terms of trajectory, in terms of also your fluoro angle as well, in terms of that. But most of these patients don't have CT due to creatinine or some other reasons. And so it's absolutely take your time during the TEE screening and also on the table. But, here are some, challenges, which I certainly seen before, Ryan. I'm sure you too, in terms of hyperelastic septum. And you can see here in fluoroscopy that the needle in this case, courtesy of my colleague, you can see that jump. And I'm like, oh dear, when I see that, I'm a little bit scared in terms of where it has jumped, and even in the TE as well. For those hyperelastic, those interatrial septal aneurysm, those flimsy interatrial septum. So these ones can be quite challenging. And the other challenge I find, Ryan, is the thick fibrotic septum. You can see in this case, and you really sometimes have to go through this thick fibrotic septum. And I think for these cases, right, we use a lot of balloon septostomy, after we cross. What do you think?
Yeah. Oh, absolutely. I think if there's any question in terms of how the dilator passes through from the right to the left side, if it doesn't pass freely, take the time to do the balloon, because if you find out when your MitraClip guide is going up that you can't get across, then that is coming out. You have to put a dry seal sheath to seal the groin while you then go up with a balloon. So it saves that step if there's any, and you'll get that feel over the years. But if there's any question about being able to pass through, especially if it looks like this, or if it's a post-surgical septum, go ahead and do the balloon. And we use a 7x40 balloon typically. Is that what you use as well, Nadira?
Yeah, that's
Okay.
right.
Yeah.
Usually we do that. And then Ryan, when you are, when they are balloon, we images will watch it
Mhm.
as well.
Oh,
Make sure you
absolutely.
watch it as
Yep.
the balloon. Don't stop imaging. It's continuous imaging and
Yeah.
whatever he does. And so he can also see as well. Ryan will see a screen on his console as well to make sure that it's absolutely safe.
I
And
like
also, oh, go ahead.
I like to do a quick cine burst right before
Mm,
I go across so
yeah.
that I know where the septum is on fluoro. We also use echo fusion and CT fusion as a way to plan the transeptal, which feels like cheating sometimes because it is such a help. But when you have to balloon, you know where you made the transeptal, so it does help.
Absolutely. That's right. And images, make sure you also watch out for, just double, triple check any fusion, all of these parameters. I think, obviously the hemodynamics as well, just to make sure that everything is still safe while doing that. And so mentioned about I've been doing a lot of 3D MPRs. And so here you can see a patient that I recently do. You can see on the left-hand side, got a bicable and orthogonal view. It's very hard. I did multiple views to try and get to the 4-chamber and it wasn't possible. And so using 3D MPR, you can see on the right-hand side, allocating where the crosshairs are and then rotating it. And you can see on the bottom right-hand side here, this is where the mitral valve is. And so I will freeze this image and take a measurement right from here. You can see the needle poking and take a measurement from here all the way down to the mitral annulus. And we've been really successful in this. And, so, most of the cases I just double check with this. And so something to think about and to do in your practice. And so here is similar to that case. Once I confirm that on 3D, you can see here, confirming again, making sure on 2D it's safe. And then buzz he goes, you can see the bubbles across in the left atrium and certainly monitoring the needle across into the left atrium. And so, for me, I think, you can see my colleague, my right-hand side here in MHI, the communication is so important. We use the same screens. I'm sure you too, Ryan. We have a TE and I use my, the fluoro right above us. So I see what you see and you see what I see too. And we, talk the same language, right? So that we understand each other. I think that is so key, and if you don't understand, as an imager, I will ask, my interventionist and Ryan as well, what exactly you need, and be honest and be open about it. Use all the tools, 2D, 3D MPR, and of course, other modality imaging as well, like what Ryan, you mentioned, your fusion imaging, but certainly understand it, or CT in terms of those anatomical challenges. So, Ryan, what do you think?
Yeah. It's actually one of the questions from the panel was how, as a new imager, and a new implanter, how do you establish that strong partnership? Which I think the partnership is a great term to use because that is what you are trying to make. And I think using the same language is really important. And I think when it's a new team, potentially going through some old cases together, just to make sure that you are using the same language and understanding what each of you consider to be the optimal view, ideally at certain stages of the procedure. And that at a certain point, you're always one step ahead of the other person. And you start to talk even just a little bit less sometimes as you build that partnership, because you're speaking the same language, which a lot of it is unspoken. So I think going through old cases can be helpful, and really reviewing cases together before the day of the procedure is really key.
Absolutely. Reviewing those cases together, both the imager and the interventionist, either before the day before, or even on that day, even, before puncture. Once the patient is intubated, there are some cases the patient is on the table, and you pass the TE probe, everybody pause, stand, the interventionist stand next to the imager and discuss the case. Sometimes you see something new that you didn't see before, right?
Oh, absolutely. There's always surprises for sure. And don't be afraid to stop and not do the case if something changes. Once or twice a year, something completely unexpected comes up, and just stop. You can always come back.
Exactly. And I've done cases where we make a consensus decision, together as a team to say this is not the best thing to move forward. And in the patient's safety and what's not, depending on the etiology of it. So absolutely. I think that's the key decision making. And I think, the building that partnership, that's how it starts. Right, Ryan?
Yep, absolutely. And I think that someone else asked, in our programs, do we use one dedicated imager for the procedures itself? And I think most places the volume is at a level where really having one imager is probably the best case scenario if you're doing somewhere between 20 and 50 cases a year, because if you start to dilute out the procedures with more than one person or more than two people, then that it's harder to be in lockstep with each other. It's kind of my opinion. We do have more imagers doing the pre-screening, but we do have one imager doing the actual procedures.
That's right. And also, the imager who does this, the procedure, make sure, we can also spread the knowledge. I think, with the other echocardiographers, whoever's doing the TEE screening, they can also make sure that they get the necessary views and the 3D so that it helps in the decision making. Am I right, Ryan? During the valve meeting. So
absolutely. If there's a pool of people doing the pre-screening, coming up as a team, coming up with the kind of minimum that you need to make decisions. And as you said, Nadira, 3D leaflet length, really getting very clear, grasping views. And it's important to kind of set the standard of what you need if someone may need a MitraClip or some advanced therapy of that nature.
That's right. And some quantitation. So the decision making in terms of MR reduction as well. So absolutely, start small and then it was all grow big and the program will be successful. And so, I thought I'd start with a case example first before handing it over to Ryan. And this is a case I had, and, you can see here the MR and the calcium, and you can see that mitral annular calcification, not only there, you can see on the bicom view on the top left-hand side, the calcium also in the quartz, restricting the motion. But certainly you can see on the 3D as well, both in the atrial and ventricular side. So you can see on the bottom right-hand side is the true view, one of the features. I love it, but because you can see that calcium on the quartz, exactly like how you see it on the 2D. But really talking about that pre-screening. So this patient had a pre-screening. I remember this case vividly, that it was on the table. So I took my time and really assess this case. And you can see, moving, like I showed you, that commissural view, mid to lateral to medial as well. Where exactly is the jet? And majority of the jet, as you can see in the top row, really the majority of the MR jet is being central. And it's still a little bit medial and lateral to A2, P2, but majority of it, the PISA is really being central. Quantitatively, the 3D venocontractor area you can see is central, is at 76 millimeters square. Valve area a little restricted, 3.9 centimeters square. And this patient of mine is a very small lady, with a BSA, certainly less than 1.7. A mean gradient about 2.3 millimeters per mercury. And so really, we screen her for, including TMVr for mitral valve replacement, knowing the limitations of the TEER therapy. And in terms of the valve area, the gradients, we're thinking all outside the box, but she wasn't suitable for TMVr because of the risk of LVOT obstruction. And she's a very small lady. So certainly it will cause, if we put in a valve, she will have LVOT obstruction. So, and she's symptomatic, high surgical risk. And so, Ryan, I mean, what are your thoughts about this, and what will you do?
It's a tough case. We always talk about calcium in terms of in where it's located within the valve is so key. Having this degree of leaflet calcification, but also chordal calcification, we don't always see that. And I think I always get concerned about how pliable are the leaflets going to be? Are they going to come central? Is there enough sort of elasticity and pliability in the tissue when the cords are that calcified? And also we do occasionally see leaflet perforations. It's rare, but it does happen in these folks with, the older population, smaller hearts, and where there's calcium at the really where you're going to be grasping, specifically at the edge of the arm, at the tip of the arm, where the most pressure is going to be on the leaflets. And so I'm already thinking about those things. Looking at this case, I'm thankful that it's central, because that you'll be able to stay away from the cords a little bit more, and it's not super wide, so we can hopefully get away with one clip, because with this valve area, with the calcium, I think you'll probably reduce the valve area more than you would with healthier leaflets, if you will.
That you're absolutely spot on. And so, obviously we did try with MitraClip. And so you can see left-hand side, a live 3D image. You can see, my intervention is like what Ryan would do, poking, just to check the height as well. And so confirming the height of it at 4 centimeters. And then, making sure we use both 2D and 3D every step of the way. Whatever Ryan does, I will make sure that, he is safe. He's not hitting the left atrium. He's, it's safe. There's no pericardial effusion. So continuous imaging during the procedure as images to make sure it's safe. And then once he crossed the left atrium, I think a lot of us, heard about 3D MPR, multibandal reconstruction. And so similarly as well, we use a lot of it to ensure alignment and perpendicularity. And so, because it's a 4 quads, you have 2D, both bicom and the long axis, and you can see the bottom row, short axis of the mitral valve. You can rotate it in the surgical view and still remain live. And so Ryan can see it as well, and he can adjust accordingly. And you can see on the left-hand side, once it's, in the ballpark central. And so with that same view, Ryan would just push down below the leaflets. And on the right-hand side, you can see even on the same view, Ryan will talk to me, right? You will say, how am I? Am I still in the same spot, right, Ryan? And then just I need to do as an imager, just turn the gain down. And I would advocate for 3D MPR because, and the key thing about 3D is that you have to make sure your 2D is very good, because it doesn't mean that, 3D will get a very good 3D image. Your 2D image has to be so good, really ideal, and then you get a very nice 3D image of such. So take your time to get a very good 2D image and then switch to 3D. And then like we mentioned about coaptation reserve, you want to restore it and recreate it. And so, as he pulls up, once you're in the same spot, you can see the leaflets into the arm. And then most of the time you can, do this on 3D MPR, but the resolution, just be very careful. It may be a little bit hazy. It's not as clear as on 2D imaging because of the resolution. And so sometimes I will switch back to 2D, long axis view or biplane palm. And so while he's closing the clips to ensure that leaflet grabs. And so, this is, you can see here, once, it's clipped, I will reassess to make sure before deployment, to make sure that your gradients, your reduction in MR, pulmonary vein as well. And once all of that is confirmed, the clip is deployed. And so for this patient, exactly to your point, Ryan, one clip right down in the middle, an NTW, and we got away with less than, moderate, so mild MR with a 3D VTCA residual. valve area at 2, but she's a very small lady, so I don't think she'd be running. So I think, with a 2 centimeters square, she's did great even in a follow-up with a mean gradient of 3.3. And so, that is one example of a case. And then I'll switch over to Ryan, who will share more cases.
Thanks, Nadira. Those were great cases. And I think, as I'm bringing up my slides, one other thing I'll add is that I think it's really important that to speak up during the cases, but on both sides, because you're watching, as you can live in 3D as you're trying to go through the whole case, and that's ideal if you can. But when you're trying to look at 4 different boxes, sometimes you may miss that you're diving more medial than you anticipated, even if you check your trajectory ahead of time, which of course is part of the basics. But as you come below the valve, if you're halfway across the valve annulus and it looks like you're spinning or diving, feel free to, that's a good time to stop and come back into the atrium. Because if you really plan that first pass into the ventricle correctly and make sure that the clip remains aligned, it will make the rest of the procedure so much smoother. So I have a couple cases that I'm going to show. I specifically did not choose cases that were perfect cases. There are some parts of the procedure that were more challenging than anticipated. And I think it's important to share those as well. So the first case is an 81-year-old man who presents with volume overload and several months of progressive dyspnea on exertion. So he is 74 kilograms. You'll see that the MR is secondary in nature due to posterior medial LV remodeling and tethering of the posterior leaflet. And because of the tethering, there's overriding of the anterior leaflet. And so you have a difference in terms of where the leaflets want to coapt. And so you'll see that most often in primary MR cases with prolapse and flail. But sometimes, depending on if there's asymmetry in the tethering, you'll see an overriding leaflet because one is just so tethered. Because this gentleman actually had preserved ejection fraction, but had a distant PCI complicated by perforation needing emergent cabbage. And so part of the ventricle was not functioning well as a result of the failed PCI. So there was preserved overall ejection fraction, but the papillary muscle supporting the posterior leaflet was tethered. And so that's essentially how the patient ended up with AFib, atrial dilatation, and heart failure. And so on right heart cath, volume overloaded still, V waves almost to 50 on the wedge, which was confirmed when we did get into the left atrium. The grafts, both of the grafts were patent because it was a sort of an emergent bypass surgery. 2 vein grafts were placed to the left heart, one to the LAD, one to the circumflex. You can see the occluded circumflex stent, which is where the complication was. So on pre-imaging, one of the nice things that I find helpful is a biplane sweep. And so starting with the bicom view on the left, and then slowly taking that sweep through from commissure to commissure to really show all parts of the leaflet in 2D. And then on color, you can see that most of the jet is on the left side of the screen, which is the lateral part of the heart. So this sweep is really key. I find that that's a really helpful bit of information. When Nadira was speaking, I mentioned that it's helpful to be able to go back and to see what the baseline leaflet length is. And because there's, in some patients with a contracted posterior leaflet, you really want to know the length of the leaflet right in that area where that pathology is, because it can be pretty focal. But you may, because if the leaflet is very short, you may have to go on one side or the other. And so if you have a sweep through the area, you'll be able to identify the difference there. So this patient did have a severe MR with a regurgitant volume of 84 cc's, EROA of 0.47. The mean gradient was acceptable at 1.6. You can see the leaflets are pretty mobile. And one thing we haven't mentioned, Nadira, and maybe you could speak a little bit about that now, is the tenting height, tenting area. Do you still use that, and how does it affect your decision making?
That's a great question. I mean, I think, it does play a huge role. I think the tenting height, because it would matter in terms of the transeptal. And if you don't have enough height, so you consider, especially for the functional mitral regurgitation, don't you think it can give a little bit more room in tenting area as well? And I think the point of coaptation reserve, if you think it's so, the tenting area is not so large, and the height of it, the coaptation reserve is so small, it's acceptable, still doable, but challenging as well. So these are the kind of things to think at the back of your head as you grasp these leaflets, and to make sure that you have adequate leaflet length, grasp into that clip to avoid that SLDA, and you want to get as much MR reduction as possible.
Yeah, definitely on the dilated annuli that don't have much tent. Those are the left atrial myopathies. Those are really challenging, because you're asking a lot of the leaflet in terms of restoring that coaptation zone. And so when you have a shallow tent, so when we talk about tent, so when we make that transeptal, we're measuring the puncture site to the annulus usually. But when it's a secondary MR case, the tips of the leaflets may be coapting below the level of the annulus. And so it gives you a little bit of latitude, and you can puncture a little bit lower. And I'll demonstrate that as we go through this case. So another really important point that we've mentioned is posterior leaflet length. And so specifically in this case, and so it's tethered, and in the area where we want to place the clip, it's less than 9 millimeters. It's right at that cutoff. But for the long clip arms, ideally you want to have the leaflet tip come all the way down to the shaft of the device, meaning you get the entire length of the clip leaflet into the clip, and that should be about 9 millimeters. And so you don't quite have it all. You don't quite have the length that you need for a long clip. And so we were feeling the best way to go forward would be with an NT. We gave ourselves some latitude on the septal height in terms of planning, being around 3.5 or 4 centimeters would be okay. 4.5 being ideal, but we do gain a little bit of height because of the tent. Area is good, so I wasn't too concerned about that. And I already mentioned the pathology with the overriding anterior leaflet. And so we'll move on to the transeptal puncture. And so bicaval view on the left, coming down from the superior vena cava. As you drop into the fossa, you really come abruptly off that thick septum into the fossa. And I think this is a case where you really need to have controlled motion and really set up your angle of approach as you come down, because once you jump into the fossa, it may be challenging to make good adjustments. In floppy septums, and Nadira showed a great picture of that. If you're really having an aggressive tent and you're having a hard time manipulating the needle, and you're worried about puncturing through to the back wall because it may jump forward, one thing you can do is bring the system out and take some of the bend off of the needle, and that will make a little bit less of an aggressive interface between the needle and the septum, so that can be helpful. So in this image, on the picture on the left that's moving, on the right, that all the way to the right is posterior. And so you can see that I can probably get a little bit better in terms of posterior. And so when you look at the image on the right, the still image that demonstrates the height of about 3.6, I've made my way more posterior. And one way to give yourself more room posteriorly is to come to the mid-septum if you're talking superior to inferior, because the fossa is oval and circular. If you come a little bit, if you're too superior, you may run out of room when you're coming posterior. So come down to the mid-septum, and then you should be able to maximize that posterior, which is clockwise rotation on the needle. And again, taking your time, making sure that it's a good height and that it's safe before you go across. Another point to make really in these patients is that if you puncture too posterior, that brings you very high above the mitral valve. And to come down to the coaptation line and to the valve plane, if you're really high, it may be hard to make that reach. And so you can run out of room, you can run out of guide and have a hard time advancing the clip far enough into the ventricle. And also, the more guide you have in the left atrium, it increases the chance that you'll have some bias and diving one way or another. And you just have to be more patient if that's the case to make sure that you don't dive. But you can have to overreach and have a hard time getting down. Now, the other piece about the transeptal is if you're too superior, if you just barely come out of the SVC, that will bias you towards the anterior leaflet. And this relationship between the vena cava and the anterior and posterior leaflets are really important. So if you're mid-septum, it gives you the most room posteriorly, but it also should drop you down right at midway between in the AP dimension, if you will. And so right over the coaptation line, not biasing you towards the anterior leaflet or the posterior, because then you may be sweeping across and have a aorta hugger or the opposite when you're coming down towards the leaflets. So these are some nice 3D views showing that we did puncture in the mid-septum when looking superior to inferior. And so you can see we're coming down directly over the coaptation line. We usually test the grippers, so testing the tactile marker on the back. And this is a really important part to be clear with each other in terms of make sure you're both double checking that you have checked the grippers before you go down into the ventricle, but also saying, I'm testing the tactile gripper now, are you ready? And making sure that you capture it. Because if someone forgets, you can always go back and say, right, we tested that one first. But you can check it in 3D when the imaging is very clear in this case. So you can see we're testing the grippers there. I still like to do it in 2D. But these were such good pictures, I wanted to show it. And so the image is flipped on the left, just to, throw things off a little bit. So usually medial and lateral or opposite. But we're working towards the medial zone where the leak is. And you can see that as we're coming down and we're quite medial. So we're really coming down close to the commissure. And what you're seeing on the video on the left or on the right is that posterior leaflet is curling. And so taking time to really image that leaflet and making sure that the tip is making its way between the shaft and the kind of base of the arm. And so you can see during diastole, when the posterior leaflet is extended towards the apex of the ventricle, you can see the tip flickering. And then in systole, as I slowly bring the clip up, it's kind of wrapping around the tip of the posterior arm. And so that's what we mean by posterior curling. And what that means most likely, and it's hard to say for sure, but what we all kind of hypothesize is that one of the cords that is tethering is just preventing that the tip of the arm is interfacing with a cord, and so it's just not falling down into that V between the shaft and the arm. And so oftentimes what this means is that you do need to move the clip one way or the other. And so because we were already biased quite towards the commissure, we decided to move a little bit more central and to try to get away from that cord that was causing us problems on the posterior side. And so before we were able to do that, we did get stuck on the anterior leaflet because again, there's a lot, you're running into cords as you get closer to the commissure. I feel like I could write a book at this point about how to get stuck and unstuck. Hopefully the latter part is true when you do get stuck, because it does happen a lot. The advice we always give is retrace your steps. Try to undo what you did, which can be obviously easier said than done. Nadira, I don't know if you have any tips that you've developed in terms of guiding people to get unstuck, but it can be challenging.
It is. And I would say monitor whatever the interventionist is doing during this part. Very important. Biplane, get a good view, 2D, biplane it. as he untangles,
Mhm.
so-called, and get out of the zone carefully. And even after he gets out to the left atrium, I think we really need to interrogate the microregurgitation at that spot, the leaflets to make sure there's no tear, all of these things, even after he comes up to the left atrium. So continuous imaging is what I would say.
Absolutely. When you finally get unstuck, I don't breathe a sigh of relief until I see color again, and to make sure that the MR wasn't made worse. Take some time to look and make sure there isn't a new cord that's flopping into the left atrium, because that you may have to adjust your strategy if you did do something in the subvalvular apparatus. And I think adjusting slowly. And so one of the things also that I wanted to mention when you do get stuck, sometimes a cord, especially in primary cases, a bit of leaflet or cord can come between the shaft and the gripper when the gripper is raised still. And it can be sometimes helpful to bring the grippers halfway down on the side where you're stuck, to get to assess, are you coming behind the gripper, or is it or how is it interfacing, because it may affect your decision making on how to get unstuck.
And Ryan, I think we have a question, and I think that is a very good question, interesting, a very great question. It's like, how often do you think at this step where you feel that there's not enough height, do you think that you have to redo the transeptal stick? How often in such cases? That's a great question. And then, or, as an interventionist, what are the things you should avoid and instead rely on device manipulations to overcome the less optimal puncture location? And it's point of time, right? Where we try the first before we've been in those cases. That's a great question, I must say.
It is. And the more knobs that you put on the device, the less predictable a certain input will yield your desired output, just because of the tension on the system. That being said, it's hard to completely reset and make a new transeptal because of the steps that are involved. But also the maneuverability with the newer generation delivery system usually does allow you to overcome the steering usually allows you to overcome a suboptimal transeptal. Now, the caveat to that is if you're extremely high, and if you can't bring the clip down into the ventricle, that will be challenging if you can't get below the leaflets. More often, you don't give yourself enough height, and then you can't come high enough to properly engage the leaflets. And that will affect your ability to get a secure grasp and good leaflet length. So you can gain height and shed height using the knobs. And I think if you're really maxing out those knobs, the anterior and posterior and plus and minus, and you still can't get a good leaflet interaction, then maybe that's the time to do a new transeptal. What do you think, Nadira? That's a tough question.
It is, and I completely agree. I've been in cases where, this hard decision has to be made instead of standing there for another 2-3 hours trying. And, so if you don't go down that, I would say that, and if there's after an hour or two and you say, okay, I think there's a couple of steps we could improve on the transeptal. And I think really say, okay, let's start over. And it is okay. I would rather start over from the transeptal and get a great results. That suboptimal results. So I agree.
And we haven't emphasized too much yet the importance of being perpendicular. And so your clip arms have to be perpendicular to the line of coaptation, and your entry needs to be perpendicular to the annular plane. And if the more knobs you have on, the harder it's going to be to predict your movement as you come into the ventricle. So we did end up deciding that this was a good grasp. We had good leaflet length. We measured the pre and post, and the MR reduction was satisfactory, both when we had the mandrel still in place and also when we released. And then we went forward with, we checked gradients before we released, of course, but we do like to measure the two residual orifices afterwards to get a semi-quantitative assessment of the leftover area. And so we did that in this case, immediately had a small area of about 0.44 and then laterally 2.18. And so adding those together, we were in a range that we were happy with the gradient, happy with the residual area. You know, it would have been challenging to have to put a second clip in. Luckily, we got a good MR reduction with that one clip. And then on follow-up imaging, we had good reduction down to mild. And so I think the key points we wanted to drive home here, and I think we did, the successful alteration of the transeptal puncture to really to account for tenting height, and also just wear and the size of the left atrium. We were able to achieve a good result with the NT clip, how to get unstuck when you are stuck, and also how to adapt if you have issues with cords. Specifically, it's almost always posterior curling that gives you a problem on these really tethered leaflets. So we have one more case I wanted to show before we try to tackle some questions that may come up. So this is an 81-year-old man with also a secondary MR. Sorry, 74-year-old. Pre-procedure imaging as such. So class 2 to 3 heart failure. It ends up being moderate to severe MR, but certainly in the treatable range. Low ejection fraction and paroxysmal AFib. Similar body weight, 74 kilograms, dilated left ventricle, and coronary disease, prior MI, significant pulmonary hypertension, mean PA pressure of 34, right atrial pressure of 14, and the wedge 22 millimeters of mercury with V waves to 40. So this patient has a little bit of even a deeper tent because of more LV dilatation and downward displacement of the papillary muscles. And so again, going back to our standard baseline imaging, you can see the image on the right. You can really appreciate how deep that tent is, specifically at the A2P2 region. Now, I like this image because you can see both the anterior and the posterior leaflets on the grasping view. There's cords that insert into the mid body of the leaflet and affect they're restricted in their coaptation because of these cords. So not just the cords that attach to the tip, but certainly into the body of the leaflet can impact the leaflet function. But if I'm going to be grasping in this area, I feel that the working length of the leaflet is really the tip to where that leaflet or that cord inserts into the mid portion of the leaflet. Because if you're grasping here, the tip of your arm may not be able to get past that part of the leaflet in terms of leaflet insertion. That does vary depending on where you're going to grasp along the coaptation line. But what do you think about that, Nadira? Is these really extremely tethered leaflets are just so challenging because those accessory cords, I think, get in the way?
Absolutely. And that's where that imaging of that commercial view and biplaning across the suite to see where is that sweet spot where you can avoid that entanglement and where majority of the jet is. And so I'm curious to see the color imaging, I think, on your biplane imaging, to see majority, I would guess, is central. There
Exactly. You nail on the head. Now, a little bit of a surprise on the color imaging is that there were 2 jets. And so we weren't fully expecting this. So for whatever reason, the way that now it's interesting that it's a central jet, and the jet is directed central into the aorta. It's not asymmetric and wrapping around the atrium. So it's kind of interesting. It's a secondary MR jet. Usually those are heading straight back to the back of the atrium, but this is a 2 separate jets. So there is some coaptation right down the middle. But these 2 jet cases are really tough because you have to understand that potentially when you treat the more dominant jet, there's going to be an impact on that other jet. If you're specifically, if you're not lined up perfectly with a coaptation line. Is that fair to say, Nadira?
Yes, and I'm actually thinking, because I had a similar case just a few weeks ago, and I was thinking just one right in the middle, grasp both jets.
And do both, get both with one.
One big one, because because to avoid the cords, and I think in grab it because it's literally right next to central A to P2, and so hopefully the grass would just grab as much and then see how it does.
I like that idea, especially because I know how this case went.
Exactly.
So you can see on the 3D imaging, which is gorgeous, there's the jet. The prominent jet is lateral. And so we made the decision to go after that primary jet. And so everything was within range. The patient was low output with a stroke volume index of 20. And we went over a lot of the parameters already. And so this is a little bit different transeptal. We don't have that thickening of the superior part coming down into the fossa, but we were able to get posterior enough. A good sized tent there, enough that it feels secure, but not so much that I feel like we're going to dive to the back wall. Good height, again, giving ourselves some latitude, knowing the tent height is about 1 centimeter. So we accepted this 3.6 as a good height. And so this is an interesting case because sometimes when you have a lot of guide in place, when you're going after a lateral defect, it can cause a fair bit of shadowing. And so you can see on the image on the right, we lost some view of our anterior leaflet. It's because of the shadowing of the guide. It can be really challenging to overcome that because you're trying to you really want to image in that location that has the shadow. So I don't know if there's any tricks to get around that other than changing your angle of approach, which is a big undertaking, but can be done.
Absolutely. Change the angle or position of your TE. What you could do, I'll ask Ryan, step on the fluoro, see where your TE probe is, and try to move right and left away from it, and then adjust the image accordingly. Use your small wheel and see if you can actually, like you say, show the shaft, or from this image, what you could do is actually use the 3D MPR as well, and see whether you can align it and see the shaft, the whole perpendicularity and trajectory of it as well. So a couple of ways to maneuver around, and also depending on the size of the left atrium. So really use all these skills and tools and to adjust accordingly.
You can see on the bicom views we are over-emmed maybe a little bit because we're the bend in the guide. You can see it's bending and then coming back to bring us down into the ventricle, so diving medial a little bit. And so one potential way to have a better angle of approach and also maybe alter how much shadowing you have is to come back into the left atrium, pull the whole system back, and then take M off. And so you end up back where you started in terms of where you're crossing the annular plane, but you're coming at it at a different angle. And just a reminder that anytime you make adjustments like that, especially with the M knob, take your time, go back to 3D and check how your arms are aligned relative to the line of coaptation, because you may have to clock or counter an hour or so to get yourself into position. And so we measured leaflet length pre and post. We got about 0.6 6 millimeters of length, which is good for a short clip arm. And that's essentially what I anticipated with a working length of that posterior leaflet. We really wouldn't be able to get much more than that. And so going forward, sorry, the color image plays very rapidly for some reason, but we had an eccentric jet that seemed like it was in the mild to moderate range, maybe in the moderate range, but it was challenging to get into place, and we felt like it was a reasonable result. And so once we let go, you can see that there was a fair bit more MR. And so on 3D, it looks like we are counterclocked too much. Our clip probably rotated as we came up and slid along and interacted with those cords. And so we ended up putting a little bit of torsion on the leaflets with this case. And so you can kind of see that on the 3D, the anterior arm is more at like 11 o'clock. And so the posterior arm is more at 5 o'clock. And so it probably put a little bit of torsion. And so more MR than we thought we had. At least there was some shadowing. Assessing the color is harder when there's shadowing as well. But we were left with a decent amount of MR. And unfortunately, the residual jet is lateral to a clip that we already had placed quite laterally. And so we set ourselves up for a challenging circumstance where we have to bring another clip into that small area between the clip and the lateral commissure.
Ryan, can I ask,
Yeah.
sorry to interject, but I think at this point, right, and then we have another question, a great question, like this tackling this difficult case, right? It can be intimidating as
Yeah.
someone starts a program, right? And the question is, any advice, or do you think are there opportunities to invite a second implanter into the procedure to assist? That's what are your thoughts about it? I think that's a great question.
Absolutely. The answer is absolutely yes. And I think even I've brought other people into the room when we're getting the pre-imaging to get some advice on should we proceed or not, and what is the strategy. I've FaceTimed people, just to get their thoughts, in that always phoning a friend is helpful. I think these cases, this is a challenging case. There's 2 jets, a lot of tethering, accessory leaflets, not central. And I think this was one that I potentially made it more challenging than it needed to be. I think Nadira's point is so well taken. When you can, it's always safer to go down the middle. So when you can, it's certainly reasonable to start there, and probably had more leaflet length. Probably could have used a bigger clip.
Yeah, and my thought that was that, because try and grasp and see how it does. And sometimes in that case that I had a couple of weeks ago, that's what we did, and it worked. So we just left with one clip. Yeah,
definitely. Especially if there's clefts and things like that, you're not quite sure how the leaflets are going to react.
Yeah.
So thankfully, we were able to, with a very careful alignment of the trajectory, come in and get lateral to that first clip. I think in these circumstances, we sometimes say it's a one-way trip. If you're going into an area that small, it's going to be hard to come back into the ventricle. And so even more so in these instances, making sure that you're approaching perpendicular. And you can see you really only have one view here on that grasping view, but you can tell we're, at least in that view, you can see we're very perpendicular to the line of the plane of the valve. So when it's a one-way trip, take even extra care to come in perpendicular. So you can see we basically created a single orifice valve by putting 2 clips that have really closed off the entire lateral part of the valve. And we got a really nice MR reduction. Luckily, that other jet that was separate and distinct from the primary jet did not really open up. And so we got a nice result in the end, and a little bit extra blood, sweat, and tears than we would like on the average case. And so on transthoracic imaging, this is the pre-image and post, we got a nice result. Good gradient the gradient was 3.6, which is certainly acceptable. And I did mention checking leaflet insertion in terms of working length. Be careful in terms of If you think it may rotate, check another 3D image when the clip is below the leaflets. Always find a check down there. It doesn't always have to be in the left atrium. We also often, when we drop the grippers, close the clip a little bit and lock, and before closing, checking the rotation on 3D, and being aware that sometimes the ejection fraction will come down by a few points in the low EF patients, but know that the forward stroke volume has increased. Oftentimes you see blood pressure going up, left atrial pressure going down, which is the left atrial pressure reduction, certainly a sign of better outcomes for those individual patients. But I also always warn my patients that we may be looking at a lower ejection fraction when they come back and follow up. But if they're feeling better, that's really what the important thing is.
Great cases, Ryan. I mean, absolutely.
They're tough ones on purpose and not perfect cases on purpose. So I think that's where a lot of the learning is. And so I hope those were, we learn from each other through it. And I think a big part of what's been nice about the fellowship, the fellow teaching curriculum that Abbott has developed over the last few years, is that we've really established a community of implanters and imagers that can bounce ideas off of each other. And certainly, I mean, I've certainly done Zoom calls with other implanters in the country to just bounce ideas off of them before we go to the lab. And so I would encourage all of you to continue to come to the meetings, network with other implanters. Ourselves, we're always available. These cases we learn from each other, and it's fun. That's what makes it fun.
No, and to Ryan's point, I mean, feel free to contact. I'm sure Ryan would agree with me. Contact us. We're just a phone call away or FaceTime away.
Absolutely.
And
Definitely.
showcase all your cases, whatever you have, anything in doubt. It's really challenging. And we were there. We were in with you as a fellow before, and we know how it feels.
Mm-hmm.
And always reach out.
Yeah.
It's never stupid questions. So reach out, and we are happy and more than glad to help all of you.
And so I'll turn it over to Kara to give some closing remarks, and to any of the fellows out there who are graduating and finishing their fellowship next week. Congratulations.
Congratulations.
It's a very exciting time of year as that academic cycle restarts. And again, this is a career-long partnership. So please reach out to us anytime.
Oh, you guys were phenomenal. Thank you so much for exceeding our expectations with the content. And I just want to give another hand clap to our attendees. Your questions were phenomenal. And I know those that will see this on Abbott Cardio, where they will be able to see this video and visit that site and view this. They're going to gain so much from your input in the questions that you ask. So thank you for your participation. This is something we are continuing. So this is not goodbye, it's see you later. We value your feedback. We'll send an email out so that you can get the QR code and let us know what you want to hear about. Dr. Hamid and Dr. Kaple, you were phenomenal. Thank you so much. And thank you to everyone who attended. Have a wonderful night.
Thank you, everyone.
Thank you.
Bye, everyone.
Bye.